Okay, so let's look at cardiovascular anatomy. So the first thing is we're going to look at the position of the heart. So the heart lies in the thoracic cavity and it lies in between the two lungs which are surrounded by their pleural cavities. So the two lungs on either side with their pleura. So in between the two is the area where the heart is lying. That area here, between the two pleural cavities, this whole area here is known as the mediastinum. And the heart happens to lie in something known as the middle mediastinum. Now here in this image, you can see what the heart is surrounded by, and you did this in ANP1. All of the organs in the thoracic and abdominal cavity are surrounded by serous cavities. Now the heart has an extra kind of membrane which surrounds it. So this is a very thick fibrous tissue sort of bag which surrounds the heart, which is known as the fibrous pericardium. And this fibrous bag, as you can see below, it is attached to the diaphragm. So here is the diaphragm. So you can see that the heart is actually resting on the diaphragm. And this fibrous pericardium above is fused with the blood vessels which enter or leave the heart. So up here, that's where it's fused. Now when we open up the fibrous pericardium, we'll see another layer inside. So let's look at some of the coverings of the heart. So the first covering of the heart is this fibrous pericardium, which I told you is like a very thick bag which surrounds it. Imagine a brown paper bag. And then inside that brown paper bag, if you were to put a water-filled balloon, and then you pushed the heart inside. Can you see how the heart would go in? So the second bag, that water-filled balloon, is what is known as the serous pericardium. And that has two layers, parietal and visceral. So here, if we look at this image, so if we are looking at this image, this outer layer, which is this gray, thick one, this is the fibrous pericardium. Inside it is the serous pericardium, which, because it's been pushed in by the heart, now has two layers to it. The outer one, which is this one, in close contact with the fibrous pericardium, this is known as the parietal layer. So this is the parietal layer of the serous pericardium. And then it gets reflected, and here it surrounds the outer surface of the heart very intimately. So this layer now is known as the visceral pericardium. Okay, have you followed? So what I was saying was, imagine you had a brown paper bag like this, and that is the fibrous pericardium. And inside that brown paper bag, if I had a water-filled balloon, I had this water-filled balloon, and then I had the developing heart kind of push it inside. So what will happen to this water-filled balloon? This is how it will become, and the heart will be present here, right? Follow? And then, of course, we have the fibrous pericardium on the outside. So here it is, the fibrous pericardium. So can you see this first green layer will be called the parietal layer, and this will be called the visceral layer. Have you followed? And the visceral is going to be in intimate contact with the heart itself. The parietal layer is going to be in intimate contact with the inner aspect of the fibrous pericardium, right? The inner aspect of the bag. In between here, this part here, which is this area here, which has now become this way, this is what is called the pericardial cavity. Have you followed? Right? And these same layers, if you look at it in a section here you can see fibrous pericardium. This is the parietal layer of serous pericardium. This is the pericardial cavity. This is the visceral layer of serous pericardium. And then this is the heart muscle. Okay? So let's look at the layers of the heart. So the outermost layer of the heart, which is this one, is known as epicardium. And this epicardium is nothing but the visceral layer of the serous pericardium. Because that visceral layer is intimately attached to the outer surface of the heart, it forms the outer layer, which is also called the epicardium. So up here, this one here would be also known as epicardium. The next layer of the heart is the thickest layer, which is muscular. It is made up of cardiac muscle, and that is known as endocardium. So this layer here, this is called myocardium, not endocardium. This is called myocardium. I apologize. This is myocardium. And the innermost layer of the heart, which lines the cavities, the innermost layer of the heart, which lines the cavities of the chambers and becomes continuous with the blood vessels, this innermost layer is known as endocardium. Okay? So from outside in, first is epicardium. Remember, epi is outside, endo is inside. So epicardium is the outermost layer of the heart. Myocardium is the middle layer, M and muscle. And endocardium is the innermost layer. Okay? Let's answer this question. Does the heart lie in the pericardial cavity? So think of that picture that you just saw. So does it lie in the pericardial cavity? No, the heart does not lie in the pericardial cavity. And here's why. If you go and look here, the heart is only, look at this picture here. See, this is that water balloon and the heart pushes inside. This is the cavity. This is the cavity. The heart is not lying inside the cavity. The heart is only surrounded by the pericardial cavity, okay? And what lies inside the pericardial cavity is very little fluid, which allows frictionless movement of the heart, because as the heart expands and contracts, it allows that movement, okay? So all of these serous cavities, even when you do the pleura and then the peritoneum, none of the organs lie within the serous cavities. They're only surrounded by them. Okay, let's look at this question. James is stabbed and there is bleeding in the pericardial cavity. So where do you think the blood is lying? The blood is lying between the parietal and visceral layers, not between the fibrous and parietal pericardium. Again, to go back and look at this image. So look at this image. This is the pericardial cavity. It is present between the parietal and visceral layers. Look at this. This is the pericardial cavity between the parietal and visceral layers. So if there's blood, it's going to be between the parietal and visceral layers. For those of you who answered, you said it was between the fibrous and the parietal pericardium. That is here. That means it's going to separate the two layers. There is no cavity between those two layers. Okay? So that's why it's lying between the parietal and visceral layers. Now let's look at the borders and surfaces of the heart. And in order to understand that, let's see how the heart is in your body. And take a look at this. This is as if you're looking at the heart from the side view up here in this picture. So imagine if you had the heart and you were looking at it from the side, okay, like this. So I've drawn it this way. So you're looking at the heart from the side. This aspect is the anterior aspect. This aspect is the posterior aspect. This aspect is the inferior aspect, but this is where it's sitting on the diaphragm. So it's also known as the diaphragmatic surface. Have you followed? This anterior aspect would be in relation to the ribs and the costal cartilages. So we call this anterior surface. We also will call it the sternocostal surface. This is the posterior surface, which is also known as the base. And the inferior surface, like I said, is also known as the diaphragmatic surface because the heart rests on that, on the diaphragm. So let's look at the borders of the heart first before we start with the surfaces. So if and I'm going to erase this, and if I was to draw the borders of the heart is somewhat like this. Okay, somewhat kind of a little four-sided figure. So here is the right border. The R stands for right border. Then this becomes the inferior border. This becomes the left border, going all the way up here. And then going across like that is the superior border. So can you see how a figure like this has been drawn? Okay. The entire right border, which is this, is formed by the right atrium. The inferior border is formed, as you can see, by the right ventricle and the left ventricle. This point here is it forms the apex of the heart. And the apex of the heart is formed by the left ventricle only. It lies about 9 centimeters from the midline in the 5th intercostal space on the left side. So you all know the heart is kind of shifted more towards the left. So this lies in the left 5th intercostal space. This apex, we can feel the apex beat over there. This left border is formed by the left ventricle. Here, all of this is the left ventricle and a part of the left atrium. So this part of the left atrium, this small area of the left atrium, it's an ear-shaped process. So it's known as the left auricle. The word auricle means ear-shaped. So the left border is formed by the left auricle. The entire left atrium does not show up on the anterior surface. Most of it is seen posteriorly. Only a small part of it called the auricle is seen anteriorly. So the left border is formed by the left ventricle and the left auricle. And this superior border is formed by the left atrium as well as the right atrium. So both atria form the superior border. And this is the superior. The S stands for superior border. So you can see this is the part where the superior border is, left atrium and right atrium. Now here let's look at surfaces. So this entire surface which you see up here, this entire surface that you are seeing, this is going to be in contact with the sternum and the costal cartilages on either side. So therefore, this is known as the anterior or sternocostal surface. Followed? Underneath, up here, if I was to turn the heart around, this lower part would be called the diaphragmatic surface. And what's on the back there would be called the posterior or the base. Okay? Now, how this has been, the heart has been turned, but it has been turned in such a manner that you are seeing part of the base or posterior surface of the heart, but you're also seeing a part of the diaphragmatic surface. Have you followed? It's not been turned totally to show you only one aspect, but it's been turned in such a manner that you're seeing even the base. So you're seeing this part as the base of the heart, and you're also seeing a part of the diaphragmatic surface. But from this you understand the diaphragmatic surface will be this area here, which is formed by both ventricles on the lower aspect, right? This part here will be the diaphragmatic surface, and I'll show you another image to show you that. And then this, because this is the apex, this part is the apex, anything opposite the apex in a triangle, if this is the apex, this would be the base, right? So if this is the apex, the base would be somewhere here, isn't it? This part. So that's why we say, so here is where the apex is. That's why the posterior surface is also known as the base. So here what you can see is all of this area is the base. So this is where it's showing you the posterior surface. But you're also seeing a small part of the inferior surface, which is also called the diaphragmatic surface. Have you followed? Okay. So what is the base formed by? The left, mainly by the left atrium, a very, very small part of the right atrium. And this inferior surface is formed again by both ventricles, right and left ventricles. Now let's see, how do we decide which is the right ventricle, which is the left ventricle, which is the atrium, right and left. So in order to do that, you have certain external grooves or what are known as sulci. And based on where they are present, if they are present between the atria and the ventricles, we call it an atrioventricular groove or sulcus, atrioventricular sulcus or groove. And if it is present between the ventricles, we will call it an interventricular sulcus or groove. Okay, so the name itself is self-explanatory. Now, the atrioventricular sulcus also has another name. It is also known as coronary sulcus. It's called coronary, the reason being that when you look at the heart, this atrioventricular sulcus goes around the heart like this. And it's got blood vessels which lie in the sulcus, specifically arteries. And these arteries give off branches which come down in this manner. So it looks like an inverted crown. You know, if I kind of drew a crown, typically it looks like an inverted crown, and the word for crown is corona. So this comes from that, coronary meaning like a crown, but only it's inverted. Followed? So let's see here. So here if you look, you can see this deep groove which is present, and you recognize these grooves because you have blood vessels present in them. So this groove which is lying between a chamber above and chambers below, this is the atrioventricular sulcus or coronary sulcus. So you can see it begins from here, runs along, it will turn around this where the right border meets the inferior border, and then again go across right here and come back along the left side and again go back here. So can you see that? So this is how it's going all the way around and coming back. So where it goes around posteriorly, you can see here. This divides it into atrial chambers above and ventricular chambers below. That's why it's called atrioventricular. These atrial chambers are lying superiorly because it helps, because blood has to go from the atria into the ventricle. So it's nice to have them on top because then by gravity they can go into the ventricles. Okay? Now, how do you differentiate between the two ventricles? So, between the ventricles, you have a sulcus which is present anteriorly and posteriorly. We call it the interventricular sulcus because it's between the two ventricles. So, this part which lies anteriorly is known as the anterior interventricular sulcus. So, you can see here, anterior interventricular sulcus. It will wind around this inferior border, and then we see it on the inferior surface coming back and where it joins this coronary sulcus. So this part is the posterior interventricular sulcus. Okay, this part is the anterior interventricular sulcus. To the right of it is the right ventricle. To the left of it is the left ventricle. And again up here to the right of it is the right ventricle because this has been just turned here. So this is the right side. So this is the right ventricle. This is the left ventricle. Okay. And again, as a review, if you look at the borders of the heart, here you can see right border. And let me just use a different color. So right border, inferior border, left border, and then superior border across here like this. Okay? See that? Can you also see now in this how only the left ventricle forms the apex of the heart, because this is the apex. So it's only this ventricle which is beyond the interventricular sulcus, and that's the part which is forming the apex. Right? Here again, this part is the base of the heart, most of it being formed by the left atrium. So the left atrium, most of it lies posteriorly. And a small part of the posterior surface is also formed by the right atrium. So right atrium lies both posteriorly and you can see it's also lying anteriorly. Okay. Left atrium, it's only this little ear-shaped part which is here, which is called the auricle, which you see on the anterior aspect because the rest of it is seen on the posterior aspect. Followed? Again, if you look at the chambers here, you can see the sternocostal is very clear. And here it's showing you the base and the diaphragmatic surface. So the base I already described, left atrium as well as right atrium. And the diaphragmatic surface again formed by both ventricles, right and left, because both of them sit on the diaphragm. Okay? Here, I also want you to pay attention to a fetal structure called ligamentum arteriosum, which we'll do when we do fetal circulation. And you can see it is connecting the pulmonary artery to the aorta. So this ligamentum arteriosum connects the pulmonary artery to the aorta. So let's answer this question as a review. On which surface is most of the left atrium seen? And I just actually told you. Posterior, yes, very good. Now, let's say the radiologist tells you that the inferior border of the heart has shifted and the chambers which contribute to this border have enlarged. So, which chambers is he referring to? So, in other words, which chambers form the inferior border of the heart? Yes, very good. The left ventricle and the right ventricle. So this is just a review for you. So, giving you all which chambers form which borders and which surfaces. So here now let's look at the cardiac cycle. So one thing to remember in anatomy is veins are usually colored in blue, arteries are colored in red. The reason being that veins carry deoxygenated blood and arteries carry oxygenated blood. So, based on this side, just by looking at this, which side of the heart do you think carries deoxygenated blood? The right side or the left side? Right side, right? Because just based on color. So, that's one thing important for you to remember. So, let's look at the cardiac cycle. And important things to remember here are, one thing is it's a one-way flow. Blood goes forwards. It doesn't go back. Things are done to prevent it from going back. You have valves which allow only one-way flow. Okay, valves, openings which are guarded by valves. Second is, as I mentioned earlier, the atria lie superior to the ventricles, as you saw. It makes it easier because blood goes into the atria. So atria are often known as receiving chambers. So atria are receiving chambers. So blood goes into the atria. And ventricles are what we can call as output chambers. The ventricles, because blood goes out from the ventricles. While we are doing this, one thing to remember, they are receiving chambers. Veins take blood towards the heart. So veins take blood towards the heart. So therefore, atria are receiving chambers and veins are taking blood towards the heart, which automatically means that veins will go into the atria. Is that right? Okay. Arteries take blood away from the heart. Arteries take blood away from the heart. Ventricles push blood out of the heart. So it stands to reason that ventricles will be pushing blood into the arteries. Right? Okay? So let's look at the cardiac cycle. Now this happens in both sides, right and left simultaneously, but I'll kind of go in order just to show you. But remember, it's happening simultaneously. As both atria receive blood together, both push it into the ventricles and both ventricles push blood out into the arteries. But I'm just going to go step by step, okay? So here's the right atrium. So blood comes into the right atrium by means of veins. Remember, veins were going into the heart, right? So it has two major veins opening into it, superior vena cava and inferior vena cava. The superior vena cava brings blood from the upper part of the body and the upper limbs. The inferior vena cava brings blood from the lower part of the body. With a few exceptions, we can say above the diaphragm is superior vena cava, below the diaphragm is inferior vena cava. There are some exceptions which we'll do when we do circulation. There are other veins too which open into the right atrium, but let's just look at this blood which is being brought back by veins from the upper part and lower part of the body. It gets into the right atrium. From the right atrium, it goes into the right ventricle. So it travels into the right ventricle, and in order to make sure that there's only a one-way flow, there is an opening which is present here, and because it lies between the atria and the ventricles, this opening is known as the atrioventricular opening. So this one will be the right atrioventricular opening, or also called the tricuspid valve or tricuspid opening, which is guarded by this valve. Okay, there's an opening there and it has to be guarded by a valve so that the valve ensures one-way flow. So it comes from the atrium into the right ventricle. This is venous blood, so it's going into the right ventricle, so it will still be deoxygenated. From the right ventricle, the blood now will pass out. Remember, ventricles pass it into arteries. So it passes it out into an artery which is called the pulmonary artery. So this initial part of this pulmonary artery is often called the pulmonary trunk. So this part here is known as the pulmonary trunk, and it divides into a right and left pulmonary artery because they go to the lungs. So this is one exception to the rule where an artery is not carrying oxygenated blood but it's carrying deoxygenated blood. Remember, I said arteries normally carry oxygenated blood. This is an exception to the rule. So it goes to the lungs where the blood is exchanged, gas is exchanged. So, the carbon dioxide in the pulmonary arterial capillaries are given into the lungs, and oxygen from the lungs gets back into capillaries, and we form veins. Those pulmonary veins open into you can see here, they open now into the left atrium. So from the lungs, by means of pulmonary veins, you get into the left atrium. So again, see the difference. The veins are red in color because they're carrying oxygenated blood. So that exception to the rule. From the left atrium, blood goes again through the left atrioventricular valve into the left ventricle. This valve is also this left atrioventricular valve, left AV valve, is also called the mitral valve, or also called the bicuspid valve. Then from the left ventricle, blood is pumped out to the aorta. So this big artery, it goes into the aorta, which is guarded here by an opening, and this is called this one here is called the aortic opening, and the valve will be the aortic valve, just as this one here was the pulmonary opening with the pulmonary valve. So you can see now, and then from the aorta, the blood goes to the entire body where oxygen is given, then veins form, and then they come back, and then the next cycle starts. So it enters through superior and inferior vena cava. Okay, follow? So let's look here at the cardiac cycle.
The heart is a pump which must circulate blood through two different but interconnected vascular systems. The smaller of these systems is the pulmonary system. Blood returning from the upper part of the right atrium by the vena cava, one of the body's two largest veins, while blood returning from the lower part of the body is delivered to the right atrium by the other major vein, the inferior vena. The right atrium in each cardiac cycle forces blood into the right ventricle. This is followed by contraction of the right ventricle, which pumps into the pulmonary artery through the lungs. As the right ventricle contracts and pressure in the rises, the tricuspid valve situated at the opening between the right atrium and right ventricle shuts, preventing any. The pressure generated by contraction of the right ventricle soon opens the pulmonary, blood enters the circulation. After passing through the circulation of the lungs, the blood, having been recharged with oxygen and having rid itself of carbon dioxide, is returned to the pulmonary veins to the left atrium. The left atrium, too, contracts, forwarding blood into the left ventricle in order to fill it before it contracts. As the left ventricle contracts, the mitral valve shuts, preventing backflow into the left atrium. The aortic valve and blood is forced into the tributes into the rest of the body apart from the lungs. As contractions to an end in the aortic walls, the aortic valve snaps shut to prevent backflow into the left ventricle.
So see how cardiac is very important to understand this cardiac really things in anatomy. Okay? Now let's look individually at the chambers. So we are looking at the right atrium. So whenever you're looking at a chamber, first of all, you should know the features of the chamber, and then you must know what are the openings in the chamber and any special features in that chamber. So let's look at both atria. So common features of both atria are they both have a smooth part. So you can see there's a smooth area to the chamber, and they have a rough area to the chamber. That rough part is made up of muscles which kind of look like the teeth of a comb. So they are known as musculi pectinati, or also known as pectinate muscles. So both atria have that. So here are the pectinate muscles in the left atrium. So there you can see this part here is where the pectinate muscles are. These pectinate muscles are very common in that ear-shaped part of the atria, which is known as the auricle. Remember, I showed you those auricles? So in the ear-shaped part of the atria, that's where these pectinate muscles are most common. So both atria have a smooth part and a rough part. The rough part is called musculi pectinati. Second, both atria are separated from each other by a septum because, you know, it's a chamber. So there's a wall between the two. And these septa are internal. Okay, they are on the inside. So because it's between the two atria, this septum is known as the interatrial septum. So this septum you're looking from the right atrial side. Here you're looking at the septum from the left atrial side. Okay, so it's the wall between the two atria. So this is called the interatrial septum. So it's like a wall. So you'll have a right side to the wall and a left side to the wall. On the right side of the wall, so which is visible in the right atrium, you actually see a depression in the wall. That depression is known as fossa ovalis. And this is a remnant of a fetal structure. In fetal life, there was an aperture or a hole present, and that was known as foramen ovale. When the baby is born and starts crying and the lungs become functional, this foramen ovale closes off and its remnant is seen, and it's known as fossa ovalis. So it's seen as a depression in the interatrial septum, but seen on the right atrial side. Now let's look at some of the openings that we see in the right atrium. We already saw the superior and the inferior vena cava, which bring blood from the body, upper and lower parts of the body. Another opening you see is the opening of the veins which drain the heart itself. So all these veins which are draining the heart, so they drain the heart, that they open into a common vein which is known as the coronary sinus. So here you have the opening of the coronary sinus. Then we have some veins which are these veins which you can see, these ones. These are called the anterior cardiac veins. These veins do not open into the coronary sinus, but they drain or open directly into the right atrium. So we have the anterior cardiac veins, instead of going into the coronary sinus like most of those veins which drain the heart, these go directly into the right atrium. And then every chamber of the heart has small little veins which are known as venae cordis minimi. Every chamber, or both atria, both ventricles. By the name itself, it says venae meaning vein, cordis meaning heart, Minimi meaning small. So small veins of the heart. So little veins kind of open into every chamber. They're so tiny that they don't have length to go and drain into any other major structure. So they just open directly into every chamber. And then we also have this opening whereby the right atrium communicates with the right ventricle, which is the tricuspid opening guarded by the tricuspid valve. Okay? So these are the openings in the right atrium. Let's see the openings in the left atrium. Pulmonary veins. So these pulmonary veins here, remember they brought blood back from the lungs. So we have 4 pulmonary veins, 2 from each lung. So pulmonary veins. Then the left atrium communicates with the left ventricle by means of the mitral or bicuspid or the left atrioventricular valve, which is guarded by the cusp or leaflets. And then venae cordis minimi. So mitral opening, pulmonary veins, and venae cordis minimi. So these are the features of this chamber, okay, the atrial chamber. Any questions? So let's answer this question. Sulci and grooves are external and septa are internal. Is that a true or false statement? True. Septa are internal, sulci are present on the outside. So this is a true statement. We call it a groove when it's on the outside and septum when it's inside between chambers. Now, read these statements carefully. Which of the following statements is not true about the right atrium? Okay, yes, most of you got it right. Pulmonary veins, they don't open into the right atrium. Remember, they are opening into the left atrium. Okay, so it does contain musculi pectinati. Both atria contain musculi pectinati. That was the rough part of the atrium. So this is a correct statement. This is incorrect. This opens into the left atrium. Now let's look at the ventricles. So here's the right ventricle. And again, some common features of both ventricles. Both ventricles again have a smooth part and a rough part. The smooth part in the right ventricle is known as the infundibulum. So in the right ventricle, that smooth part is called the infundibulum. In the left ventricle, I'll show you, it's called the vestibule. The rough part of the ventricles, where you will see that the myocardium is kind of looking rough like this, you know, like we had musculi pectinati. Only the name changes here. Instead of being called musculi pectinati, this rough part is known as trabeculae carni. So the rough part in the atria and ventricles have different names. Trabeculae means like a network. Carni means fleshy, carnivorous. So it's more fleshy and more you know, like networked. So that's why it's called trabeculae carni. Like the atria, we have a septum between the two ventricles. So here it's called the interventricular septum. So here this is known as the interventricular septum. Now the septum is such that between the two ventricles, if you took a cross section of the ventricle, so if I was to take a section of the ventricles, you would find that the left ventricular wall is much, much thicker than the right ventricular wall, because the right ventricle just has to send blood to the lungs, whereas the left ventricle to the whole body. So the left ventricular wall is much thicker. And this interventricular septum kind of bulges towards the right ventricle. So can you see it? The shape of the right ventricle is kind of more or less triangular, whereas the left ventricle is more circular. Okay? So left ventricular wall is thicker and the septum bulges towards the right ventricle. Another common feature with these ventricles is that in both ventricles you will find arising from the trabeculae carni are little protruding muscles which are known as papillary muscles. So can you see these little sort of pointed muscles sticking out? These are called papillary muscles, and these papillary muscles are attached to the atrioventricular openings. So on the right side it will be tricuspid, on the left side it will be mitral or bicuspid. So these papillary muscles are attached to the cusps or leaflets of that valve which guards the atrioventricular opening by means of thin cords. Can you see these thin cords? These are known as cordi tendini, meaning tendon-like cords. Okay? So I'll repeat again, both ventricles have papillary muscles. In both cases, the papillary muscles are attached to the tricuspid valve or the bicuspid, depending whether it's right or left side. And they are attached by thin cord-like structures which are known as cordi tendini. Now, in the right ventricle, why do you call it tricuspid and why do you call it bicuspid? Because in the right ventricle, this valve, the tricuspid valve, it has 3 leaflets. So 1, 2, and 3. So that's why it's called tricuspid. On the left side, that atrioventricular opening, you'll see has only 2 leaflets. So that's why it's called bicuspid. These leaflets are also called cusps. So 2 cusps, so bicuspid, 3 cusps or tricuspid. Okay? Followed? Let's see some special features of the right ventricle. Only in the right ventricle, going from the interventricular septum and towards this papillary muscle, this anterior papillary muscle, you have a band of cardiac tissue, part of that trabeculae carni, but it has a special name. It's called the moderator band. It's only present in the right side, and this moderator band actually transmits part of the conducting system of the heart. And we'll see it when we see the conducting system. The opening seen in the right ventricle, tricuspid opening. So here we can see the tricuspid opening through which blood comes from the atrium into the ventricles. And then from the right ventricle, blood has to go out into the pulmonary artery. So the second opening is this pulmonary opening here. So blood passes through this pulmonary opening, which is also guarded by a valve. And these valves here, they look very different. Can you see these leaflets of this valve? They are flat, right? They're absolutely flat. But look at these. These are kind of different. So these valves which guard the pulmonary opening or the aortic opening, these are known as semilunar valves. These are called semilunar valves. What I also want you to see that these papillary muscles are attached only to this atrioventricular, in this case tricuspid. Can you see that there is no papillary muscle or cordi tendini attached to the semilunar valves? Can you see that? So that's why you must look at these pictures very carefully. Okay? And the other opening in this chamber is the venae cordis minimi. Remember I said it opens into all chambers. So if this is not in your list, you can add this. Now, what is the importance of these papillary muscles and these cordi tendini? Why are they attached only to the atrioventricular valves? The reason is that this valve, this opening, allows blood to go from the right atrium into the right ventricle. And if you watched that video, you saw that when the right ventricle contracts, it wants to push blood into the pulmonary opening. If this valve was open or if this opening was wide, what would happen? Blood would go into the pulmonary, but it could also backtrack into the atria, right? You don't want it to happen. You want one-way flow. So you want this valve to be closed when the ventricle contracts. So you want the atrioventricular valves or atrioventricular openings to be closed off when the ventricles contract. So what happens is when the ventricles contract, these papillary muscles also contract because they're part of the trabeculae carni. So what they do, when they contract, they pull these cordi tendini towards them. When they pull the cordi tendini towards them, the cusps, all the cusps get close to each other. They get pulled like this. So when they get close to each other, what happens? The opening closes. And the leaflets are prevented from being pushed back into the atria. You understand? If these valves are incompetent, suppose for some reason they're not functioning properly, what will happen? When the ventricle contracts, the valves will not close properly, so blood will then go back into the atria, which would be harmful, right? We don't want that to happen. Have you followed? So the function of the papillary muscles is to pull on the chordae tendineae and bring the leaflets close together, close the AV valves, and prevent them from being blown back into the atria. Followed? The semilunar valves, I'll show you how they close in the next slide because this doesn't show it that well. So let's look at the left ventricle. So here in the left ventricle, here you can see clearly. So here is the trabeculae carni. So you can see this network. Again, you can see the papillary muscles. Notice these papillary muscles are attached to this mitral valve. The mitral valve has only two cusps or two leaflets, 1 and 2. So that's why it's called bicuspid. So when it contracts, it will pull on the chordae tendineae, which will bring the leaflets close to each other and prevent them from being blown back into the left atrium. This is the next opening, which is the aortic opening. And this smooth area here, this is the part which is called the vestibule. Now here, if you look, you can see how these aortic and pulmonary valves are different from the mitral and tricuspid. Look at these leaflets. They are flat. Look at these leaflets. Can you see they are like half moons? That's why they are known as semilunar. Can you see that? And in between these leaflets and the wall of the aorta or the pulmonary artery, there is a little space. Can you see the space? This space is known as the sinus. So this is present in both pulmonary and aortic. So when the ventricle contracts, it will push blood into the aorta. So on this side, on the left side, and the right side, it will push it into the pulmonary artery. So as the blood is flowing into the aorta or pulmonary artery, what it will do is it will make these leaflets be pushed against the wall. So the sinuses will become absolutely flat. Okay? Now, as the ventricle relaxes, what will happen? Blood is going to try and come back into the ventricle. When it tries to come back, it will flow into these sinuses and fill these sinuses. So with the result, the sinuses become like little cushions and the three leaflets get very close to each other and they close off that opening. So when they are filled with blood, this is what they will look like. Can you see that? They are filled like this. Can you see how they'll close off the opening? Do you see that? So the closure of the semilunar valves or the aortic and pulmonary is due to filling of these sinuses. Have you got that? Closure of the AV valves is because of the papillary muscles pulling on the chordae tendineae. What I also want you to see in the left ventricle, you notice first there is no moderator band, but there's another special feature. In the left ventricle, because the left ventricle gives rise to the aorta which carries oxygenated blood, the first blood vessels which come out of the aorta are coronary arteries. So here are notice the two openings for coronary blood vessels. So this is another opening here. So these openings are the openings for coronary arteries. So when the ventricle relaxes and blood fills these sinuses, that blood actually goes into the coronary arteries and that's how it helps to supply the heart itself. Okay, so can you see how strategically these coronary openings are placed very inside or very close to those sinuses so that they can fill with blood when the ventricle relaxes. Okay. The openings are in the left ventricle, mitral, aortic and the venae cordis minimi. Okay, now look, knowing the cardiac cycle, suppose the pulmonary valve was narrowed. Where do you think blood would first back up? So the pulmonary valve is narrowed. So it's very difficult now for blood to go out. So where is blood going to back up first? Which is the first chamber which is going to be involved? Yes, it's going to be right ventricle, because remember, right ventricle pushes blood out through the pulmonary opening to the lungs. So if the pulmonary opening is narrowed, imagine a narrow hose. So right ventricle cannot push blood out. So it's going to remain in the right ventricle, right? It's going to back up. It's like plumbing. So the right ventricle will be the first one which would be affected, not left atrium. Blood cannot back up in the left atrium. In the left atrium, it would back up if the pulmonary veins there was some problem with the mitral valve, not even pulmonary veins, with the mitral valve, right? Because that's why you need to know the cardiac cycle. And not in the left ventricle. It would back up in the left ventricle if there was a problem with the aorta, from where the left ventricle sends blood into the aorta. So if the aorta is narrowed, it cannot send blood out, so it would back up in that, okay? So think of normal plumbing. Yeah, you have a question?
Okay, so if the blood backs up, what does that do to the heart?
Well, if the blood backs up, if it backs up a lot, you can get something known as congestive cardiac failure. So what will happen to the heart is that the chamber will enlarge, because it has to accommodate more blood than normal, isn't it? The chamber will enlarge. Plus, also that now the heart is the right ventricle is going to try to contract more forcibly to push against a narrowed opening. So the muscle will hypertrophy. So you see, its demand for oxygen will increase. So you can see what a lot of other problems it's going to have. Okay, we already did this. So the backflow of blood from the ventricles to the atria is prevented by closure of the atrioventricular valves, right? Remember, from the ventricles to the atrioventricular valves. Let's look at the blood supply of the heart. So this is through, as I mentioned, the coronary arteries. The heart is a very, very selfish organ. It first has to supply itself with blood first before it can function, right? Because unless it supplies with blood itself with oxygen, it cannot function properly. So there are two coronary arteries, the right and left. So here are the branches of shown in red are the branches of the right coronary artery, and shown in kind of this orange are the branches of the left coronary artery. So you follow my thing. So let's look at the anterior aspect. So here's the right coronary artery. Remember, it came off from the aorta, and this part of the aorta that it comes out is known as ascending aorta. And it, near that sinus, aortic sinus, it travels in the coronary sulcus. As it's traveling in the coronary sulcus, about 55 to 60% of the time it gives off this branch to a part of the conducting system. So this is called the SA nodal artery. Then it gives branches to the right atrium, because it's any artery lying close to a structure will always supply the structure. So it gives branches to the right atrium, travels in the coronary sulcus. It gives branches to the ventricle, just called ventricular branches, no specific name. And then as it's coming towards this inferior border, it gives off a long branch, which is known as the right marginal artery, or right marginal branch. So you can see this long branch along the inferior border, okay? And then it will turn around and we'll see it on the posterior aspect. So this is the right coronary artery. Let's look at the left coronary artery on the anterior aspect. So it arises as a short stem, and you can see the stem here from the ascending aorta. Immediately divides into two major branches. One which lies anteriorly, which is known as the anterior interventricular artery, because it's lying in the interventricular sulcus, or it's often also called LAD, for left anterior descending. So LAD, okay? And the second branch winds around this left border. So this second branch is called the circumflex branch. So this left coronary divides into LAD and circumflex branch. Let's look at the LAD. It gives branches, because it's lying in the interventricular sulcus, it will supply both ventricles. So you can see it's giving branches to the right ventricle, gives branches to the left ventricle. It has some branches which are rather large, which are called diagonal branches. And this interventricular sulcus is the position, shows you the position where the interventricular septum is going to be. So what this anterior interventricular branch does is it sends branches down in a perpendicular manner to the interventricular septum as well. So you can see these are called interventricular septal branches. So it sends branches there. And then it winds around this inferior border, and we'll see it on the posterior aspect, okay? The circumflex branch turns around like that, and it often gives a branch which is lying along the left margin. So this is known as the left marginal artery. And then now let's look at the posterior aspect. So first let's follow the left since we were describing that. So here is this this circumflex branch. So this circumflex branch again gives branches, as you can see, to the left atrium. It gives branches again to the left ventricle. So some of them are named. Sometimes you just call them posterior ventricular branches. And then it travels in the coronary sulcus and comes very close and often meets the right coronary artery. So there's kind of a superficial anastomosis between the two, meaning joining of the arteries. The right coronary artery, remember, it turned around and it gave that right marginal branch. Now when it comes around, in about 90% of the time, it gives off a branch to the AV node, which is not shown here. But in about 90% of the time, and I don't see it here, it gives off a branch, so I'm going to draw it here, which is called AV nodal artery. And then gives a major branch which travels in the posterior interventricular sulcus. So this branch is called the posterior interventricular branch. Again, it's interventricular, so it will supply both ventricles. And it will also give branches to the septum, the interventricular septum. Just like the anterior interventricular did, this also will give perpendicular branches which go down and supply the interventricular septum. Okay? Now, for the veins, I'll show you another picture, but what I want you to see in this picture, so you must see which veins travel with the posterior interventricular artery. You can see here this vein is the middle cardiac vein. And if we go back to the previous picture, look at this right marginal artery. We have a big vein which travels with it, which is called the small cardiac vein. And with this anterior interventricular artery is this vein called the great cardiac vein. It travels with the anterior interventricular and then part of the way with the circumflex, okay? So these three veins, the small cardiac, the great cardiac, and we saw on the posterior aspect, the middle cardiac vein, this one, these are three major veins and you must know what they travel with, okay? So let's now look here at coronary artery. So here is showing you a more clear picture of the right coronary and the left coronary, so you can kind of label this for yourself. I'll show you the veins. So here you can see this is the anterior surface and what is shown in light color is the posterior surface. So on the anterior surface, traveling with the anterior descending or left anterior descending or anterior interventricular is this great cardiac vein, and then it turns around and it will travel with the circumflex branch and it drains into the coronary sinus. So this left great cardiac vein will turn around and drain into the coronary sinus. This coronary sinus opens into the right atrium. On the posterior aspect, traveling with this posterior descending or posterior interventricular artery is this vein called the middle cardiac vein. So it's traveling with that and it also drains into the coronary sinus. So you can see that the coronary sinus is draining the great cardiac, it's also draining the middle cardiac. And this middle cardiac actually starts from the anterior aspect and you can see it's winding around here. But most of its journey is with this posterior descending. Along the inferior border is this vein called the small cardiac vein, which travels with this right marginal artery. It also turns around and drains into the coronary sinus. So you can see that the coronary sinus is receiving all these major veins. There are other unnamed veins which drain into the coronary sinus. This vein is called the oblique vein of the left atrium. So most of the venous drainage of the heart is through the coronary sinus, which then opens directly into the right atrium. So it's taking back venous blood from the heart into the atrium. However, we have some veins called anterior cardiac veins, which are these, which open by themselves into the right atrium. So notice how they are not opening into the coronary sinus, but they open separately into the right atrium. So they have separate openings in the right atrium, okay? So if you were asked, all of these drain into the coronary sinus except, your answer would be anterior cardiac veins. And remember also those venae cordis minimi, those tiny veins which drained all the chambers. So here are kind of giving you the coronary arteries and veins branches. Conus branches are those branches which are right at the beginning, which supply. The conus branches are these branches which are going towards the pulmonary trunk. You see these? These are called conus branches. So just in case you're confused, these branches are known as conus branches. Okay? So these conus branches. So here you can see these are the review for all of these. Let's now look at the conducting system of the heart. Now the heart muscle with the myocardium, it has an inherent rhythmicity. It is able to contract on its own, but it is influenced by the autonomic nervous system. And here in this picture you can see this autonomic nervous system has a parasympathetic part and a sympathetic part. The parasympathetic part decreases the heart rate. So through the vagus nerve it sends impulses and it decreases the heart rate. So the heart rate from say 80 would come down to 60. It will bring it down. The sympathetic nervous system, on the other hand, increases the heart rate. So, when you're scared, for example, your heart rate sort of goes up. And it also increases the force of contraction. So the heart contracts more forcibly. The parasympathetic has very little effect on the force of contraction, okay, if at all. So it only acts on the heart rate. Now, what actually makes the cardiac muscle contract and what is it that the sympathetic and parasympathetic influence? Inside the heart, there are specialized cardiac muscle fibers or tissue, and these form what is called the intrinsic conducting system of the heart. They decide how the heart is going to beat, when the heart is going to relax, how the impulses will pass. So, right in the right atrium at the opening where the superior vena cava opens, there's a collection of tissue which is known as the sinoatrial node. This is known as the pacemaker of the heart because it sets the heart rate. And usual heart rate is close to about 72 beats per minute. Some people have it a little less, especially athletes, because their parasympathetic tone is very high. From the sinoatrial node, fibers, specialized tissue goes to another node also present in the right atrium called the AV node. And from here it also goes into the left atrium. So you can see some specialized fibers will go into the left atrium so that the impulses are transmitted to the left atrium as well. Then from the SA node, so therefore the impulses come to the AV node. From the AV node, they go into a bundle which is known as the bundle of His, so that the AV node now helps to transmit the impulse from the atria to the ventricles, and there is a slight delay so that the atria contract first and then the ventricles contract. You don't want both of them contracting at the same time. This bundle of His divides into two branches, one for the right ventricle, one for the left ventricle. And you can see how they diverge. And then they finally kind of get distributed just below the endocardium as a subendocardial network. And the muscle cells there are very special and large, and they are known as Purkinje cells. So this subendocardial network is made up of Purkinje cells. Now here I want you to notice, look at this part of the conducting bundle. This is what goes into the moderator band. So notice over here, it's going into the moderator band. See, on the left ventricle, you don't need a moderator band because this papillary muscle is very close to the septum. So the conducting tissue goes directly into the papillary muscle, making sure that the atrioventricular opening is closed before the rest of the ventricle contracts. On the right side, you need this moderator band to be present so that the conducting tissue and impulses can pass to the AV node, closing it before the ventricle contracts, because you want it to close before the ventricle contracts. Otherwise, what will happen? Blood will go back into the atria. Okay? So that's the purpose of that moderator band. I'm going to skip this because you have this in your notes. So let's see this. So you looked at the interventricular septum. So if the interventricular septum had a defect, do you think it would affect the conducting system, the conduction system? It would. Notice this. Suppose that when I say it has a defect, I mean if there's a hole in it. So look at this picture here. See this. This is the interventricular septum. Can you see this bundle of his is passing through the interventricular septum? So if there was a big block over here, a big hole, what would happen? You would affect the conducting system, right? Because the conducting system would be directly affected. Similarly, can you notice how this AV node and the bundle of his is very close to the interatrial septum? So even with an interatrial septal defect, it could be affected. Okay, so that could be a problem. So any of the septal defects can affect the conducting system. This is a little bit on blood vessel histology. Blood vessels have 3 tunics or layers. The innermost layer is known as tunica intima, which is made up of little connective tissue and the endothelial lining. So it's got the endothelial lining. The middle layer is known as tunica media. So this middle layer is tunica media. Here you can see it is much thicker in an artery. Tunica media is much thicker in an artery compared to a vein because an artery has to contract more forcefully. And then the outermost layer is known as tunica adventitia or externa. So this is the outermost layer, tunica adventitia or externa, which is much larger. The layer is much larger in a vein than in an artery. So compare it, look at the artery, the adventitia is much thinner. Because a vein, you don't want it to collapse. So you need little more connective tissue on the outside. When you reach smaller blood vessels, the media automatically becomes smaller. And by the time you reach capillaries, they only have the tunica intima. They don't have media or adventitia because in a capillary, you want gas exchange to occur. So you don't want walls to be very thick. So capillaries lack tunica media and adventitia. They only have the intima. Veins also tend to have an irregular lumen, whereas arteries are more circular because of the muscle layer. Let's look at some clinical conditions. First is atherosclerosis. This is where a cholesterol plaque is deposited. A cholesterol plaque is deposited on the blood vessel wall. So what will it do? It will cause narrowing of the vessel wall. So blood, it becomes very difficult now for blood to pass through. So if it is in a large blood vessel like the aorta or the pulmonary artery, then the ventricles have to contract more forcefully to push it out. If it is in the coronary blood vessels, what will happen? It will narrow the coronary blood vessels, so blood will not pass through. So the heart, myocardium will not get oxygen, right? So if it doesn't get oxygen, you might end up with something known as ischemia, which is lack of blood supply. And if that ischemia, if there is total blockage, then the heart muscle dies and you get something known as infarction or myocardial infarction, which is the same as heart attack. So you can have temporary ischemia where, the blood vessel is just narrowed. So if somebody is doing some exercise, the oxygen deprivation is much more. And so when they stop the exercise, they may feel okay. That is known as angina. Sometimes, however, if the blood vessel is totally blocked, like by a clot, then the myocardium is not getting any blood supply at all. So it undergoes total ischemia and causes cell death, and that's known as myocardial infarction. I already told you about these septal defects. You may have times when the septum is not formed or it doesn't close properly. So you may have a hole in the interatrial septum or interventricular septum. When you say a hole in the heart, a child is born with a hole in the heart, most often it's a septal defect. And that foramen ovale, which is the one between the two atria, that could remain open. And the child is born with it, and that's what is called a congenital heart problem. And sometimes these septal defects could involve the conduction system. So apart from the fact that there is mixing of blood between the two chambers, you'll have conduction problems as well. And then I told you about where there was fluid in the pericardial cavity between the serous and visceral layers. It often starts out with an infection. Suppose somebody has a viral infection that can kind of irritate the pericardium, which begins to secrete fluid. And when it secretes fluid, it will because that fibrous pericardium is an unyielding bag. It's like a very thick thing. It doesn't expand. So if the fluid continues to build up, then it will compromise the working of the heart. The heart will not be able to fill and will not be able to contract properly. Or, you could have a stab wound, like somebody gets stabbed, and you could have fluid within the pericardial cavity, and again, it will compromise the working of the heart. So, these are very dangerous situations that a person could get into. I think that wraps it up.